So we are going to discuss vasogenic edema. You know that if this is a blood vessel and this is brain, what happens due there is this disruption of this barrier, and there is leakage of this protein-rich fluid that gets accumulated in the extracellular space here, and this gets accumulated more in white matter. So vasogenic edema you see more in white matter because the density is low, so fluid can seep into this white matter easily compared to gray matter, and this extracellular protein rich fluid leads to morbidity, because if we allow it to accumulate in that region, then it can cause brain herniation as well. Now the question is, we use dexamethasone, and how does it prevent vasogenic edema from formation? The reason is, actually what happens is, there is formation of vascular endothelial growth factor, and this is increased within the tumor, and this VEGF, also other things like glutamate, leukotrienes, uh, this VEGF is responsible for this loss of integrity of blood-brain barrier in tumors like gliomas, meningiomas, and like metastatic tumors of brain. These are the tumors where vasogenic edema frequently develops, and you have to put the patient on DEXA prophylactically, or even if patient deteriorates, for example in the form of patient develops new onset headache, or for example patient develops seizures or focal neurological deficits, or even encephalopathy patient develops, then you have to suspect that patient has developed vasogenic edema and you have to give dexamethasone. Dexamethasone, how does it act? First, for that we have to know what VEGF does to the blood-brain barrier. Actually, what it does, VEGF is created by tumor cells, and it binds to its receptors, that is VEGF receptor 1 and receptor 2, which are located on the surface of the endothelial cells. And VEGF, what it does, if this is for example endothelium cells, it creates a gap between endothelial cells, due to which there is leakage of fluid into the brain parenchyma that leads to vasogenic edema. Now if it's unchecked, this cerebral edema is left unchecked, then it will definitely lead to this fatal herniation of brain. Dexamethasone simply, and this it down regulates VEGF. So this VEGF, which is actually a strong permeabilizing factor in astrocytes and pericytes, this dexamethasone inhibits also formation of interleukin-1 from tumor-associated macrophages in glioblastoma models. It has been seen like this. Now, if, for example, post these things like post-tumoral, if patient develops headache, what are the characteristics of that headache? Headache will be like this dull type of headache, throbbing headache. It can be throbbing pain. It is usually diffuse. It's usually bilateral in nature and may be felt unilaterally on the side of the tumor. And quality of the pain is often described as dull, oblique, throbbing pain. So what happens sometimes, if it depends upon the amount of the vasogenic edema. For example, if amount of vasogenic edema increases, then the headache type becomes that of increased ICP type. What is the type of headache that we see? What is the characteristic feature of the type of headache that we see in increased intracranial pressures, we see that it becomes worse in morning. So it becomes worse in morning, and it can be associated with nausea and vomiting. So in this case, if patient's headache is of subacute uh, variant temporally, and now that it has increased to such a degree that it becomes worse in morning and associated with nausea or vomiting, then you have to suspect, provided it is provided this case is diagnosed early. That means you already know that is a case of glioma, meningioma, or metastatic tumor, and you have ruled out any new onset bleed or ischemic stroke. Then only you can suspect that the vasogenic edema has gone up, and you have to jack up the dose of DEXA. Sometimes patients, since we know that increased pressures within the brain can lead to other things like drowsiness and other manifestations like pre-syncope as well as syncope. You see, for metastatic brain tumors in particular, focal vasogenic edema is often the dominant cause of symptoms rather than the tumor itself. For example, if a patient has developed new posterior, this frontal brain metastasis, and he has developed new onset weakness, then you shouldn't attribute this weakness to the tumor itself. Rather, the peritumoral edema is leading to these things. So you have to this perilesional edema, peritumoral edema, perimetastatic lesion, new lesions. The edema in its vicinity is causing the new symptoms. So when you start DEXA, you will decrease vascular endothelial growth factor, and what will it lead to? It will decrease this vasogenic edema. So you will see that there is disappearance of white matter lesions on MRI, and you will see that the patient experiences complete recovery of strength upon initiation of this glucocorticoid, even before this tumor specific therapy is initiated. Now, on MRI, two things in T1 and in T2 are flare. We see hypointense, and here we see hyperintense. And note that it does not enhance after contrast administration. So if you do see MRI, you won't see enhancement. Whereas in case of, and note that what happens in cytotoxic edema, is associated with water diffusivity on diffusion-weighted MRI. We will talk about cytotoxic edema later, but note that this is associated with water diffusivity on diffusion-weighted MRI. And note that one characteristic finding of vasogenic edema is, since the density of white matter is low, that's why vasogenic edema tends to respect the boundaries of white matter. Whereas in case of infiltrative tumors, for example glioma, tumors will not respect the boundary. Also, sometimes what happens is vasogenic edema, we know it's reversible. Clinical effects with dexamethasone or glucocorticoids per se will improve upon initiation of glucocorticoids, but neuroimaging, these white matter lesions may take days and up to weeks sometimes. So how do you treat this vasogenic edema? We know vasogenic edema will actually lead to this increased intracranial pressures, which can manifest in the form of headache, drowsiness, coma, or there can be other signs of impending herniation. Like, when do you suspect that the cerebral herniation will occur? For example, if there is worsening of sensorium first. Second thing is, for example, you see unilateral or bilateral this fixed dilated pupils. Third, you see, for example, there is development of rigidity, like decorticate oblique decerebrate rigidity, you see. And what you see is uh, if patient develops like complicated meningitis like features, so the dose of dexa that you have to start is you have to give stat dose of or bolus dose of dexamethasone 10 mg IV you have to give, and it should be given acutely followed by 16 mg per day. That has to be divided. You can give 4 mg like in the form of 8 mg. You can also give like 8 mg BD. So this is the dose, and sometimes you can go as up to 40 mg per day as well, in case in the emergency setting for this brain tumor related edema or this mass effect. Other approaches like hypertonic saline and menthol you can give. Sometimes the use of dexamethasone is contraindicated, and you have to replace it with other steroid. That we can, in that case, we can use prednisone in place of dexamethasone. So contraindications of using dexamethasone are like if a patient has steroid myopathy. In such case, you cannot use dexamethasone. You have to use prednisone. Also, in a patient who has a history of adrenal insufficiency, um, you have to use prednisone. Why? Because prednisone has one quality that this prednisone allows you to taper it in small increments. That is the advantage of prednisone. So dexamethasone is contraindicated when patient has steroid myopathy or when patient has a history of adrenal insufficiency. You use prednisone, and because it allows you to taper it in small increments. We know that most patients who are asymptomatic, like who have vasogenic edema but symptoms are absent. So vasogenic edema is present but it's mild, it's not giving symptoms to the patient. Then in such cases you can omit using steroids, but you have to be cautious when you initiate anti-tumor therapy that has the potential to worsen this edema. In that case you have to initiate rapidly. Also, in case of posterior fossa tumors, which can be associated with rapid deterioration, you have to be cautious about initiation of steroids there. Note that which symptoms improve better or quickly with this initiation of dexamethasone. Headache. Headache tend to respond better and more quickly than focal deficits. Why? Because these focal deficits may be due to other causes as well. You have to try to taper the steroids, like especially in patients who are on high doses, like greater than 8 mg daily. Otherwise, it will lead to this proximal muscle weakness and weight gain can occur. Sometimes there can be refractory edema. In such cases, what we have to do is surgical debulking of the associated tumor may be required in some cases, or in other tumor histologies we use bevacizumab. Bevacizumab we can use. Bevacizumab is an option. If globally elevated ICP is the main source of refractory headache, then we have to go for shunting. So dexamethasone initiation is not without side effects. You have to consider side effects of dexamethasone. For example, it will cause insomnia. It will lead to proximal myopathies. It will lead to behavioral changes like in the form of agitation. Also, it can lead to this essential tremors. Patient can sometimes develop hiccups as well. So patient should know about these complications, and Now, three complications are of particular concern to the patients with brain tumors. So, in brain tumor patients who are started on steroids, you have to take note of three important complications. One is uh, gastrointestinal complication. Second is steroid-induced myopathies, mostly proximal myopathies. Third is infection, that is PCP. Now here we have to take note this PCP. We know PCP is a life-threatening opportunistic infection that occurs in these immunocompromised hosts, like patients having brain tumors treated on chemotherapy or treated with these steroids. Treating with steroids is in turn an immunocompromised state, and when a patient of brain tumor is receiving or is expected to receive more than 4 weeks of glucocorticoid treatment with a dose equivalent of greater or equal to 20 mg prednisone or greater or equal to 3 mg OD of DEXA, then patient needs to be put on treatment for a PCP prophylaxis with trimethoprim sulfamethoxazole. So, if a patient, for example, patient of meningioma, suppose this is a case, patient of meningioma, oblique glioma is having, for example, uh, this new onset development of headache or focal neurological deficit or worsening of encephalopathy, what you do, you initiated steroids and patients improved. But one thing he developed is cough, oblique dyspnea or fever. He developed a combination of these three things. Then what additional treatment should you put this patient on? You have to put the patient on trimethoprim sulfamethoxazole because you have to keep high index suspicion for this uh, pneumocystis pneumoniae. Now we know this HPA axis can get suppressed with the initiation of these steroids, exogenous steroids. When do you suspect that patient patient has achieved this suppression of adrenal hormone synthesis? When 20 mg prednisone has been given per day for like greater or equal to 3 weeks, or greater or equal to 3 mg DEXA has been given for greater or equal to 3 weeks, or in patients who have clinical Cushing's. In such cases, when after for example 3 weeks, or in a patient who has clinical Cushing's syndrome, you stop. For example, at any point of time, if someone mm, stops this prednisone or DEXA or steroids, then patient will end up in adrenal insufficiency. So that's why patients who have got a history of adrenal insufficiency, you don't treat them with DEXA, rather you treat them with prednisone. Since DEXA is a potent drug and has long duration of action, prednisone and is also DEXA is also associated with other complications like gastritis, perforation, proximal myopathy. So you don't, when you require only small amount, why do continue with DEXA? So prednisone has this advantage over this DEXA because it can be tapered to smaller doses, and if a patient has proximal myopathy, then you have to switch over to prednisone, and you have to suspect this. But note that when you are going to when you are going to taper this prednisone and you want to taper it, and your if patient cerebral edema has, for example, settled, clinical symptoms have got improved, and you want to taper it below physiological replacement levels, but you are suspecting that patient has been receiving this prednisone or DEXA drug for a long time now, for example, be it only 2 weeks, but still you have to keep this in your mind that patient might have developed this adrenal insufficiency. So you have to give challenge. You have to give ACTH, concentropin stimulation test, before the glucocorticoid dose is lowered below physiological replacement levels, that is approximately 0.5 to 1 mg daily of DEXA. So before going below this level, you give ACTH or concentropin test, and if cortisol levels improve, then you can lower this dose, and you can rely on patient's own adrenal glands that they will be synthesizing the necessary cortisol levels required for proper functioning of the body.